Thank you. Let's see, it's not projecting. What do I have to do? There we go. The objectives of this presentation are to examine the associations between previous incarceration and linkage to HIV care, retention in care, antiretroviral therapy, and outcomes for low-income, hard-to-reach populations, HIV-positive populations in Los Angeles. As we all know from this conference, prompt linkage to and retention in care is essential for HIV-positive persons. And better linkage and retention in care can promote individual patient survival as well as decrease transmission of HIV to partners in the community. It's become well known that incarceration in jail or prison is common for HIV-positive persons. It's estimated that as many as 1/7 of the U.S. population passes through incarceration annually. And it is thought to be a barrier to HIV prevention and treatment efforts. However, little is actually known about whether previous incarceration is associated with delays in linkage to HIV care, retention in care, antiretroviral therapy, or health outcomes. As I mentioned, incarceration is central to the HIV epidemic. A lot of attention has been paid to transmission of HIV while people are incarcerated, and attempts have been made to distribute condoms as a way of interrupting transmission during incarceration. However, this study is really focused on what happens once people are released from incarcerated settings and how it impacts their care. A few studies have been done on this topic. A few prior observational studies of prisons have shown that after release, patients have very low prescription filling rates. And this is important because when patients are being treated while they are in jail or prison, they're typically given only 2-week supply of antiretroviral therapy. So it's important for them to be linked to care on the outside and then given new prescriptions. However, studies have shown that the prescription filling rates are low. However, at least one study did show that when there is immediate post-contact with a case manager, that this improved their linkage to substance abuse treatment and lowered their sexual risk behaviors. However, data on the actual linkage to care, as well as retention and outcomes, is lacking. For those of you who don't know, the HIV epidemic in California and Los Angeles is primarily about 80% due to MSM transmission. And here I'm showing this is my pointer. I'm showing the rates of, or the HIV prevalence among men in prisons, 1.4%, and women, 1.7%. And prisons are distinguished from jails in that prisons are long-term incarceration. People are generally in prison for a number of years, whereas in jail, these are short-term incarceration, people awaiting their sentencing or who are incarcerated for short-term violations. And it's been described as a revolving door for patients who are HIV positive, and therefore many opportunities for transmission in the community as well as while incarcerated. Studies have shown that the prevalence rate among men is 2.7% and women 1.0%. This map just shows Los Angeles County. It's a huge county, and several metropolitan cities can fit within the size of it. It's the largest geographic metropolitan county in the country. The dark blue and somewhat less darker blue areas show the higher prevalence areas for HIV And you can see that it's concentrated in central and south central Los Angeles, some in East Los Angeles, and a few other epicenters on the west and south side. These are low prevalence areas in the outlying district. The red star marks where the LA County Jail is located and where our future studies are being done. We piloted an intervention, which was a peer navigation intervention. This is a patient-centered care approach to help patients navigate complex healthcare systems. It was originally designed for cancer patients in New York. In general, it targets underserved populations to decrease treatment barriers. And the central element of navigation, as opposed to case management, is accompaniment, which means that the staff person goes along with the patient to the healthcare visits. Navigators are also usually culturally matched or have the same illness as the patient, and therefore sometimes are called patient or peer navigators. So in the study that I'm presenting today, we developed and implemented a single-arm pilot peer navigation intervention. And then we conducted multi-mode comprehensive evaluation with structured surveys and medical record reviews. Interviews were conducted at baseline, 3 months, and 6 months post the intervention. I'm only presenting the baseline and 6 months today. We also collaborated with kind of a harmonized effort with 9 other sites nationally. And on the basis of that, we published at least 12, I counted. Those are the papers I was involved with. I know that there were a number of others on engagement and retention between the end of the study in 2006 and 2009. And then in 2010, we were funded by NIDA to conduct the Seek, Test, Treat project, as well as harmonized data collection efforts that Ann Kurth talked about. So what I'm presenting today has 3 parts. Part 1 is a retrospective analysis looking at incarceration history as a predictor of time to first HIV primary care visit after their first HIV test. Part 2 is a cross-sectional analysis, again with incarceration, looking at the association of incarceration with HIV care visits, missed visits, and antiretroviral therapy. And then part 3 is prospective and looks at changes post-intervention in visit frequency, barriers, and health outcomes, pre and post peer navigation intervention at 6 months follow-up, stratified by incarceration status. The methods, the sample was 223 low-income, hard-to-reach HIV-positive persons across Los Angeles County. The setting was high prevalence areas in Los Angeles, as I pointed out on the map, including South Central LA, East LA, and Skid Row in Central LA. The project was funded by Health Resources Services Administration. It's another federal administration, not NIH, for those of you who are not from the US. And this was a special project of national significance outreach initiative. This is the overview of the data collection. We actually started out with a qualitative phase. We conducted 6 focus groups. We then did face-to-face interviews, as I mentioned, at baseline in 6 months. They were conducted in English or Spanish, and the follow-up retention rate was 78%. We also conducted medical record reviews, both paper and electronic, for visits, CD4 count, and viral load. We also conducted or collected intervention logs and did a fidelity and process evaluation interviews. This is all for the local Los Angeles site where I was directing this study. Other designs or other methods may have been used at other sites around the country. The peer navigation intervention was grounded in social cognitive theory. The peer navigators were paid HIV-positive African American and Latino men and women who demonstrated successful retention and care. And we conducted a series of individual sessions delivered in person by accompaniment with transportation to medical appointments, and the goal was to increase knowledge, skill building, goal setting, and providing support and role modeling. This was the question that we asked. This is really a post hoc analysis based on this question alone in terms of assessing incarceration. We asked, have you ever been in jail or prison more than awaiting trial or court appearance? And it was yes, no. The dependent variables for the three parts of the analysis included linkage to care, that was time to first primary care appointment. Retention was assessed through 4 measures. The number, whether or not they had missed appointments reported at baseline, the number of visits that they had in the prior 6 months reported at baseline, antiretroviral therapy use, and barriers to care that were elicited through a multi-item scale. In part 3, we assessed the outcomes of viral load suppression as well as SF-12 physical and mental health summary scores. This is the item for part 1 that we asked. After you first tested HIV positive, how long was it before you saw a healthcare provider for your HIV? The analyses, we started with sample characteristics stratified by incarceration status. To assess the part 1, we used the multiple linear regression with incarceration history as the independent variable and time to first HIV care visit as the dependent variable. In part 2, we conducted multiple logistic regression analyses to examine the association between incarceration history and ambulatory medical visits, 1 or more missed appointments, and antiretroviral therapy use. For part 3, we conducted stratified analyses to examine the association between incarceration history and change in visits between baseline and 6 months, barriers, and health outcomes. Then parts 1 and 2, we controlled in these models for sociodemographic and clinical variables. In part 3, I present the bivariate analyses, but we also conducted subsequent control for these in multivariate models and didn't substantially change the results. For clarity, I'll present the bivariate results for part 3. Here is the stratified analysis showing the sample characteristics. You can see that those here in this column who had previously been in jail or prison were more likely to have a low CD4 count, lower than 350. They were also, but they were less likely to be uninsured, somewhat surprisingly. The previously incarcerated samples much more likely to be Black, but less likely to be Hispanic. In terms of risk group, they were less frequently MSM and more frequently drug users. Here's the main result from part 1 of the analysis. In the linear regression of days to seeing an HIV provider after testing HIV positive, we see that having been incarcerated was positively associated with more days before seeing an HIV provider. So there were more delays in initial linkage to care for those who had been incarcerated. For part 2 of the analysis, we see, actually none of these results are significant at the 0.05 level. The stars indicate trends at 0.2 and 0.3 level, but you can see that the point estimate for 1 or more missed appointments was elevated with odds of 1.61, showing a trend towards more missed appointments, and as well as trends towards fewer ambulatory visits and ART use at baseline. However, none of those achieved 0.05 significance. For the part 3 results, looking at change in outcome variables from baseline for incarcerated here, versus non-incarcerated here, you see that among the incarcerated, visits went up significantly. They went up almost a comparable amount for non-incarcerated, but were not significant, probably due to the smaller sample size. ER visits, an indicator of poor continuity to primary care, did not change significantly for incarcerated. However, for the non-incarcerated, they did actually reduce, which was a positive result of the intervention. Note that both comparison groups received the intervention. In terms of currently using antiretroviral therapy, it went up a number of points in the total sample, and when we stratified for those who had a clear indication at the time, less than 350, you recall, was a clear indication for antiretroviral therapy. And when we stratified for that, you see that the improvement was even greater and achieved significance. Interestingly, for the never incarcerated, it was high already at baseline as well as follow-up. In terms of change in barriers and health outcomes from baseline to 6-month follow-up, the number, having one or more competing need barriers went down 20 points among those who were incarcerated, and 11 points among non-incarcerated was not quite significant. Undetectable viral load went up significantly in the incarcerated group, a bit less so in the non-incarcerated. And although small numerical increases, it went up significantly in terms of both mental and physical health SF-12 scores in the incarcerated group, and really didn't change in the non-incarcerated group. So in summary, the previous incarceration was associated with longer times before first seeing an HIV provider after testing HIV positive. At baseline, there was a trend, a non-significant trend towards more missed appointments and less ART use. And post-intervention, there were clearly significant improvement in terms of reduced barriers, improved antiretroviral therapy used, reduced viral load, and improved SF-12 scores. There were quite a few limitations to the analyses I presented. It's a small sample size. It was a small, single-arm, uncontrolled pilot intervention. Some of the analyses were retrospective, some cross-sectional. The strongest ones were prospective. There was also some missing data. However, we did multiple imputation as to the extent that we could. It didn't really change the results very much. However, it did limit the power of the analyses. And most data are self-reported. However, the key visit data as well as CD4 count and viral load were validated by medical records, and we published the paper on that. It was impressive how well people did by self-report. So in conclusion, we found that previously incarcerated people had average delays in linkage to care of about a month after testing HIV positive. Perhaps not a huge delay, but this is on average. Some people had much longer, of course, and some had none. We also found that upon linkage, there was some tendency toward worse retention and care and less ART treatment. However, the good news was that they did respond well to the pilot intervention in terms of reduced barriers, improved ART use, reduced viral load, and improved SF-12 scores. So the implications of the study include the issue that previously incarcerated face many unique challenges to successful care and prevention that should be addressed in future studies, and that peer navigation appears to be promising for testing in a randomized controlled trial aimed at improving linkage to care, retention, and care and outcomes. And of course, the good news about that is that we have such a study that's now funded and underway, funded by NIDA as part of the Seek, Test, Treat initiative that Dr. Kurth presented earlier, and that hopefully we will have results before long. to begin to present at future meetings. I'd like to acknowledge collaborators and staff who worked hard on the project. There were others in addition to these, but these were our strongest and most consistent staff, I thought, should definitely be named.